It's our role as a university in Fond du Lac to educate not only our students and provide learning opportunities for our faculty and staff as well, but to educate the community as well, the Fond du Lac community and the broader Wisconsin community. And we do this by bringing to the academic and Fond du Lac community the annual symposium. This is our 8th annual symposium, and we're proud each year to bring to the forefront a topic for a very timely and controversial topic for discussion within the confines of a values-based institution. This year we've chosen healthcare reform, and it must be a dynamite topic because we have had tremendous participation, tremendous engagement. I would like to thank all of the people that have been involved in this process. I start with thanking Agnesian Healthcare for their role in co-sponsoring this event. We wouldn't have been able to do it without Agnesian. So thank you to all of those Agnesian participants that are here. I'd also like to thank our keynote speakers, Kevin Fickenshire, who spoke yesterday, and Jeff Bauer in advance of his talk today, and for his participation throughout the day. When we spoke to them to engage our two speakers, they said, please work us hard. They may never offer that to any organization again. They have worked. I'd also like to thank our panelists that have participated, especially today, our student and faculty presenters, as well as our presenters from the community. I'd like to again thank Agnesian Healthcare for their financial support and further financial support from the Marian University Honors Program, from the Social Justice Committee, and from the McNair Scholars Program. They have all contributed generously and allowed this event to take place. I'd also like to thank the Marian University Pre-Health Professional Club for their service on all evenings of this symposium, as well as some of the events in helping to seat people and helping evaluate, helping distribute and collect evaluations, and just making our job a bit easier. Most important, I need to thank the committee that has brought this event to light. Can I have the committee members who are here, I think we're all here, please stand and be recognized. The committee was chaired by Sister Donna Innes, and I would venture to say that everyone worked amazingly hard to bring this event to completion. At this point, I would like to introduce our speaker for the evening. Our speaker is Dr. Jeffrey Bauer. Jeffrey Bauer is our keynote. He is a nationally recognized medical economist as well as healthcare futurist. He served as the Vice President for Healthcare Forecasting and Strategy for ACS, which is a Xerox company, for over 10 years. He's published numerous articles and books on healthcare, and his latest book is entitled Paradox and Imperatives in Healthcare, How Efficiency and Effectiveness in E-Transformation Can, I don't have my glasses on, conquer waste and optimize quality. It was published by Productivity Press, which sounds like it was a good organization to publish your book, in 2008. We will have time at the end of Jeff's presentation, and we'll have time for questions, so please save your questions for the end, and we will have roving microphones take care of them. So again, I welcome you. In terms of housekeeping, there are some evaluations at your seats. If there aren't any, please ask for one on the way out or raise your hand and we'll provide you one. We look for your feedback so we know how you have perceived this and what we can do to continue serving you. We plan to do an event like this every year, and we'd like to know how it is serving you. So again, welcome, and I'd like at this point to welcome Jeff, and please warmly welcome our speaker.
Thank you, Professor Ayala. I feel warmly welcome. This is really cool. I spent about a little less than half of my 40-year professional career as a professor at 2 universities, one of them UW-Madison, and I miss it. I really do miss being part of a university. So it's been fun to be here all day. It has truly been a delight to work hard, and we've had some neat opportunities to exchange thoughts. And I'm going to share with you my thoughts tonight on health reform as a special topic within the broader context of where healthcare ought to go in the United States. And then we'll have fun going back and forth. Might be appropriate almost for any Monty Python fans in the room to think of me as something completely different. I really do have aberrant views, but I really love the opportunity to share them with people because I think they're very positive views. So when I think of the 21st century healthcare system, facts, myths, implications, and ethics, I feel very comfortable and honored to be brought before you to share those thoughts. Health reform and its impact is something I'm asked to talk about more than probably any other topic. And yet I find, in spite of the problems it presents, that it gives us some alternative futures and exciting opportunities. And that's really what I want to stress tonight. I do that with a couple of disclaimers. I want you to be aware of where I'm coming from, so to speak. And disclaimer number one is that my comments tonight are not necessarily representative of the positions of Marian University or Agnesian, nor any of my other clients. They are mine. But I love the opportunity to share them with you and engage in a dialogue that will hopefully move us all forward. The second qualification that I bring to my speaking is that I'm going to be rather critical of health reform. Anybody that's been reading my blogs or heard my other speeches or read any of my recent articles and the like knows that I've been taking a lot of pot shots at what happened in Washington and the way that it happened. So you're going to hear me be pretty critical of what was done. On the other hand, don't for a moment assume that my criticism of what the Democrats did in any way can be read as tacit approval for what the Republicans would do alternatively. I've even less good things to say about what I perceive to be the opposition's positions on health reform. I have very different views, and it's a pleasure to share them with you. But I know a few people at the end usually say, oh, you were just a shill for the minority, and that's not true. Absolutely not true. But what I do want to make very clear, and hopefully becomes abundantly obvious in the course of presentation here, is that after 40 plus years in healthcare, I really believe that we could and indeed should create the world's best healthcare system. We're far down the list right now. We get a pretty poor return on our investment. We spend 17% of our gross domestic product on healthcare. It keeps rising. And yet there are a whole host of developed countries, arguably more than 30 of them on any measure you want to use, that spend at a maximum 12% of GDP and have much healthier populations, better healthcare delivery and the like. So when you hear someone say that the United States healthcare system is the best, we, on any given day, are capable of the best healthcare in the world, but it's not what we always deliver. And yet I think we could. So please hear loud and clear in my message a vision of the opportunities that I think we have to build something that would truly be world-class. Now, I love paintings. I'm a painter in my other life. I keep the day job giving speeches because I haven't figured out how to make money at art yet, but I actually am doing a show in Chicago in a couple months. But this painting, or it's actually a woodcut by Honoré Daumier, really speaks volumes about the way I would like us to think about healthcare. And we've all been looking with telescopic precision at what went on in Washington and analyzing the charts of what's happened already, what happens in 2012, the mandated insurance and exchanges in 2014, the taxes on the Cadillac plans in 2018. You can look at the timeline of everything that's in the law, and that's really what people have been doing. I'm more like the lady, the concierge in this particular thing. Hey, look, the action's over here. And that's really what I'm saying. Don't be distracted by Washington. I'm like Toto in The Wizard of Oz. Remember the scene at the end where Toto pulls aside the curtain and the guy's saying, don't look at the little man, you know, that's got nothing to do with it. You know, the action is elsewhere, and that's really how I'm going to start the presentation today, and again, hopefully lead to a vibrant and very constructive discussion. But please remember that image. Now, I started with the premise I wouldn't do this with slides, and then when I heard several of the other presenters, I thought, no, I've got to have a few slides, get the notes organized. But these are not data-dense slides. Everything is a tweet. All the text is 140 characters or less. You can write it down. I'll be happy to make a PDF of the presentation available, so if you want any of the graphics or any of the slides, be my guest. I'm happy to share them with you. But I do have probably about, I didn't count them, 25 140-character tweets that summarize my view on where healthcare could go. And the first of these is that predicting healthcare's future is impossible because unprecedented forces are really going to create a new realm of possibilities. I really did begin working in healthcare 42 years ago. When I graduated from college, I went to work for a large Catholic hospital, Penrose, in Colorado Springs. And I ran the audiovisual department there for a couple of years, as a matter of fact, and took a lot of pictures of cadavers at autopsies and things. I was the hospital photographer. But so for 42 years, I've been watching healthcare and intimately involved in it. As a result of my experience in Penrose, decided to go get a degree in medical economics rather than return to my original field, which was research meteorology, atmospheric physics. I was originally a weatherman. And so I know something about forecasting. I also know something about predicting, and we can't do that because healthcare is right now moving in some new and totally different directions in which it has never moved before. And that's me, the concierge, pointing off, no, look over here. Here's where the exciting stuff is. Here's where we could build a good healthcare delivery system. And we're going to see more change in the decade that we are just entering. By 2020, healthcare will look so much different than it does today, much more different than it does today from what it looked 50 years ago, back in 1960. Okay, so I hopefully will, in the next 45 minutes or so, sell you on some dramatic changes, and hopefully you'll share my excitement for the way we could put things a little differently than the healthcare is perhaps organizing them and do some really neat things. But we've got to define our problems and our solutions in the context of these new resources. One of my gripes with the people who finally gave us health reform just a week or so more than a year ago was that they were basing everything on all the historical studies, the research showed. And I rather approach the kind of way that we could restructure the healthcare delivery system on what's becoming possible today. And I'll share with you pictures and stories of that. But I think healthcare organizations can optimize their own futures by strategically anticipating the changes and responding accordingly. In other words, using the new tools, looking at the new ways to deliver healthcare, because we are going to see the leaders in healthcare delivery in this country do some things that really nobody else has been doing very much. And that's what excites me. That's where you folks in Fond du Lac, people in Wisconsin in general, have opportunities to be world leaders because you really have begun research and application of some of these things. Now, because I'm a futurist, I'm always looking for other people that say good and useful things, comments that resonate with me as I put my presentations together. And almost exactly 2 years ago, Freeman Dyson, the only living American to have won 2 Nobel Prizes, a very famous physicist, back in my nerd days in the early 60s when I actually, as I say, started college as an atmospheric physics major, so I knew about Freeman Dyson. He was famous even way back then. And he turned 90 2 years ago. On the occasion of this momentous birthday, the New York Times wrote its feature article in the Sunday Times magazine about him. And I read it with rapt attention, and I just captivated totally when I saw this quote. I don't think of myself predicting things. I'm expressing possibilities, things that could happen. To a large extent, it's a question of how badly people want them to. The purpose of thinking about the future is not to predict it, but to raise people's hopes. And I might extend it, say my purpose of criticizing health reform is not to be a mean person, but rather to raise our hopes about some other ways that we could reorganize the healthcare delivery system that I think would make us much better off. And of course, you have the opportunity to quiz me on that before too long. That's tough to do. Healthcare keeps changing, and you all know, whether you're physicians or nurses or just patients, that we keep getting contradictory information. The underlying medical science is changed almost on a daily basis. So you can resonate with this cartoon as the doctor is saying to the patients, wait, all that stuff I just said was good for you, forget it, now it can kill you. Hold it, this just in, only in small doses. Can you all relate to that? We are led to believe that things are terribly important. And I have, when I'm lecturing only on the changes that are taking place in the medical science paradigm, I have about an hour and a half of slides that show this. And I just picked one of them almost at random. But we have been told for so long that fat was the problem. And we had to cut our dietary fat down under 20% of our calories. And we rushed headlong, beginning in the 1970s, into light foods. You all know what I'm talking about. And the television ads tell us to eat fat-free foods. As our consumption of low-fat foods have gone up, our obesity has increased in the United States. So we're doing, the consumption of light foods has been phenomenal, and yet we're getting fatter and fatter. Well, I've got a wealth of literature, just one slide that I brought here, saying that actually there was no research to suggest that eating lower-fat foods would necessarily make us a thinner nation. There's a lot of other things going on there. So this is just a report of a convention that was being held in Chicago, where a cholesterol research scientist said the results of cholesterol and heart study was not meant to be applied to healthy people of the world at large. And we'll look at the differences in healthy people in just a moment. Your body knows how to handle dietary fat, and if you're not overweight, have no other high-risk conditions, you can come to Chicago and have a Uno's pizza. You know? It's okay every once in a while. So we put all this emphasis into reducing our fat, and we've gotten fatter as a country in the process. What we didn't look at, and the thing that the American Dietetic Association, the American Heart Association, a variety of other organizations have suggested, is all of a sudden the literature is real clear. The culprit is right in front of us. It's sugar and the sugar substitutes. It's our sweet tooth. And so we Americans have been going for 30 plus years in the wrong direction, cutting fat. And yet we know that when you cut fat, we have natural body tendencies built into our genes to increase our consumption of sugar, to increase our consumption of liquids that contain sugar. And so the real problem that is now being reinforced by a large number of medical associations, including the American Medical Association and many of the specialty societies, is to really focus on our sugar consumption, because that's where the problem is. And we know, we had proof recently of what a bad problem we have with this in the United States, because in case you didn't hear about it, one of the East Coast cities borrowed on loan from the government, from the museum in Florence, Italy, one of the 4 copies of Michelangelo's David, this famous statue. And it was brought to the United States with great hoopla. Did you hear that a couple of years ago when they brought that over? But after just 3 years in the United States, the Italian government demanded it back. Okay? This is the story of the United States. We've done the wrong things, and that might be a metaphor for reform. We'll get to that. But I take even more perverse delight, and by the way, for the 17 years that I taught at 2 medical schools, including the 7 down the road in Madison in the Department of Preventive Medicine, I taught statistics and research. And so I follow the statistics and research pretty carefully. And so we've got all these unresearched things like the assumption that cutting back on fat would make us thinner, and it doesn't. But even the evidence for the presumption that if we just ate more vegetables, we'd get less cancer, quite frankly, isn't there. Large-scale studies have now shown that it doesn't seem to be a significant factor one way or the other. In fact, the data from studies involving hundreds of thousands of people, as this article from JAMA last year showed, is that there's actually a slight inverse correlation between consumption of veggies and cancer. In other words, but it's nothing statistically significant. So we've got a real problem that we need to take. Now I want to bring that to modern medical science and begin to address this issue of the new opportunities that we have to build a new and different healthcare system. Because in the 20th century, we had a one-size-fits-all approach to healthcare. And one of the best examples is really the first one that medical science brought to bear was when we suspected a breast tumor. And I won't just say in a woman, because 4% of all breast cancers actually happen to be in men. And in fact, one of my college classmates, a male guy named Charlie, died of breast cancer not too long after we graduated. So, but if you have a breast tumor and it's felt on palpation, or it shows up in a picture, it's got that image that a radiologist would suggest looks like a tumor, then the pathologist is called in, tissue is taken, the tissue is stained, and the doctors get together looking at the picture that the radiologist took and looking at what the pathologist sees on the slide, says, this is cancer. And then we would begin this remarkable effort to send you to the place where the right drug, the doctor was using the right drug. But the assumption was you have breast cancer and you're going to be treated the same as everybody else. But what we learned, and this is from an article that I think is just earth-shattering. This is as significant as Gutenberg's Bible or something like that in my opinion. I mean, this is really the shot heard around the world that I define as the moment, the tipping point into a new medical science. In 2003, with the knowledge, or at least with the strong suspicion based on the results of the Human Genome Project, that tumors weren't all the same. If they're all the same, everybody should get the same cure from the same drug. In 2003, a group of cancer researchers from Memorial Sloan Kettering in New York City published an article. They had gone back to their pathologists and asked the pathologists to look through their slides from 1999 and find 90 patients that, according to the pathologists, all had the same tumor. The image, as seen by a radiologist, what the pathologist saw on the slide, looked identical. So these were 90 patients that, according to the best medical science in one of the best cancer centers in the world, all had the same tumor because it looked the same in all these patients. All of a sudden, with the tools of the human genome revolution available, our ability to sequence the genetic information in front of the genetic information that's built into the slide, built into the tumor, you will, and find the instructions there, we discovered that the genes in 90 patients' tumors that looked identical actually hit about 5 or 6 different typologies. And so the yellow was assigned to one group, and unfortunately it bleaches out a little bit here, but there's 6 or 7 different colors in there. There's the yellow version of the disease, the blue version of the disease, the green, the purple, orange. Everybody with me on that? So in other words, some of these tumors that we all thought were the same, and therefore everyone was treated the same, had instructions to self-destruct. And indeed, it's pretty strongly known now in the medical community that somewhere in the neighborhood of 20% of people that have a breast tumor, it goes away on its own. In other words, there's a certain variation of this disease that is self-programmed to die, not to go anywhere. There's another version that has the instructions to grow in sight, but doesn't have the instructions in yet another one that says, go seek out a blood supply. And then there's yet another version that says, go find the lymph nodes and move into other parts of the body. See, so tumors do different things because the genetic instructions are different. And it's this article in 2003 that was published in Science, I think, was really dramatic because it showed that the one-size-fits-all approach to healthcare was missing something terribly important. So we need to begin working towards personalized predictive medicine. And we need to begin thinking that what we did, what I taught in the 20th century, to do these large randomized controlled trials, which by the FDA's procedures are set up to test a new drug against an old established drug. And so I'd say arguably throughout the 90s, tamoxifen was probably the most successful drug. So a new drug would come out. One of the drug companies had been in research for years and years, and it would do these gold standard randomized controlled trials, multi-site, large numbers of patients who took the new drug, and they discovered that the new drug only cured 10% of the patients. Only 10% of the patients who took that had a 5-year survival. 25%. Studies always pretty much showed 25% were doing well with tamoxifen. Well, what we suddenly knew beginning in 2003 is that the people that only got a 10% response rate were the people that had maybe the blue version. The people that, the 25% that were successfully cured with tamoxifen had the yellow version. And so all of a sudden we realized we had rejected a lot of drugs that weren't as good as the drug we were using based on the assumption it was the same disease, rather it was a different disease. Everybody with me on that? That is a stunning difference in the way we approach medicine. And I say it began in cancer. The very same concepts now are leading. I'd say there's arguably 5 different typologies of prostate cancer, at least 3 of liver cancer, kidney cancer has 5 or 6. You can start going down all of the oncologies and oncological conditions and find that there are enough different indicators, enough different instructions, and that means the drugs have to be matched to doing different things to stop that. We're no longer so interested in cytotoxicity. Almost all of cancer research in the 20th century was based on trying to kill that cancer drug so it couldn't reproduce. Now we're focused on just finding out what is the genetic instruction that tells a protein to unfold at a certain time, and then developing a new drug, which might be a biotech drug, a natural molecule, or a small molecule, something that you inject or take as a pill, but something that gets in there and prevents it from doing its thing. So we're not just out killing cells anymore. Now we're learning, because of these new skills that we've got, how to, this is fabulous. This is why we need biology departments, right? To get you all to go out and do that stuff. So it's really, really exciting. But I think the take-homes that this gives us is that the clinical paradigm is shifting from one-size-fits-all to personalized predictive medicine. That excites me. It ought to excite any of you in pre-med. Those of you that practice medicine, although I know it's very tough for our docs to keep up with that, and the nurses and the pharmacists, because any given day you pick up a journal and it's stunning. I gave a speech on this very topic yesterday to a group of drug industry leaders in Las Vegas in the morning. And when I talk to people from the industry, I always like to take the latest issue to prove that I didn't just make this up. So yesterday I used last week's issues. The new issues came out today and tomorrow, respectively, of JAMA and the New England Journal. But the March 23rd and March 24th issues, respectively, of JAMA and the New England Journal, the JAMA article has three of its 5 articles is on molecular differences of disease and new approaches to the pharmacology. It also includes an article on the new changes in the way we do drug research, and it has an article talking about the need for scientists to readjust their expectations of clinical outcomes. Stunningly good stuff. For any of you students, go to last week's JAMA, you'll find neat things. The last week's issue of the New England Journal has 5 of its 8 articles. 5 of the 8 featured articles are on new analysis of drugs based on the genetic characteristics of the disease, understanding how to match the disease. Really exciting stuff. And the New England Journal from last week also has a superb, and one of the best articles, I read it carefully on the flight in yesterday afternoon. It's an excellent article on what this implies for therapy, what the doctors and the nurses and the pharmacists need to do based on their new understanding. It gives real examples, dozens of examples of how suddenly their prescribing patterns, their understanding of disease is totally different. This excites me. And then I read the health reform law and I don't find it there. You know, this is where I think we ought to be focusing. It's me pointing off somewhere else. But we're now, because we were able to define these diseases that we used to think were all the same and recognize that they represent a range of biological conditions, recognizing that therapies increasingly need to be matched to each patient's specific disease characteristics. This leads me to believe, as a health futurist, that pharmacy is going to grow dramatically. Right now, pharmacy is about 11% of every dollar spent in healthcare. For every buck we spend, 11 cents of it goes to pharmacy. I will not be at all surprised to find that moving up to 15 or 16 cents per dollar by the year 2020, by the end of this decade. Because suddenly, as we learn how to find the markers for the diseases, we will go in and be able to manage these diseases in ways that we couldn't before, and to prevent the need, for example, from surgery. I have a son who's a third-year medical student right now, and for those of you who have been in medical school, by third year you've got to be starting to think what you want to do your residency in, because matches and the like are looming. So I'm having daily discussions. I talked to Frank this morning, and Frank has been thinking about surgery. But quite frankly, as a futurist, as much as a researcher, I think there's some neat things going on in surgery. But as a futurist, I don't think it's where the future is at all, because we are going to learn to intervene in everything from rheumatoid arthritis conditions, cancers, the things that surgeons do. We'll be able to bring under management with much better drugs as we improve our understanding. So that's why the general internist here sitting on the front row made the right choice, in my opinion. I'm trying so hard to get him to go into general internal medicine. But he's also thinking of radiology, because he's got some little computer that they give him at the University of Rochester Medical School, and he's not sure he can pay back his loans if he goes into internal medicine. That's why we've had these great discussions today and yesterday about the need to change the payment system, because we're moving in an understanding that's going to require a whole lot less surgery, a whole lot less intervention, but much better knowledge of the disease states. That's primary care. That's the internists, the family practitioners that can tie all of this together, working with the advanced practice nurses and the pharmacists. It's not where healthcare is leading us. Reform didn't get that particular thing. But what this means is the future of healthcare will increasingly be the management of chronic disease rather than the treatment and hopefully cure of acute conditions. And nothing is a better example than HIV/AIDS. Stop and think about it. When HIV/AIDS came out in the early 80s, and I was a professor at the time, and I remember, oh, geez, we was killing everybody. How are we going to do it? Well, we haven't cured AIDS. There's really no cure for AIDS yet. Is that fair, doctor? We've learned to manage it, however. We've learned enough about the molecular mechanisms using these same tools that I demonstrated to you a moment ago, that we now use a so-called cocktail, adjuvant therapy, a couple of drugs based on this particular characteristic of this particular patient's disease. AIDS is no longer a death sentence. You're going to live with AIDS probably for the rest of your life. We never find the magic bullet, and in fact, I don't think too much research is going there. But we've discovered that if we find the several different characteristics of each person's individual variation of AIDS, we can control it with the right combination of drugs. And that again goes back to our general internists, the other people that can look at the big picture. Now, this to me implies that the real future, the thing we ought to be getting excited about as we envision neat healthcare systems, is the team approach to care. We're not going to discover that our doctors know everything anymore. We're not going to discover that our advanced practice nurses can know everything. There is so much knowledge, not only of the genome and the molecular characteristics of the disease, but increasingly of the epigenetic factors, because study after study shows that less than half of the course of a disease is ultimately determined by the gene itself. It's all these other things, what we eat, what our cultural heritage is, how much we drink, whether we exercise. These are the factors that determine whether our genetics actually play out. If they do, how they play out. So we need teams that can bring nursing, pharmacy, medical knowledge, exercise, health education, better information access, so that people that find themselves susceptible to one of these diseases or presenting to a primary care practitioner or a subspecialist with these diseases is managed by a team. And that gets me really excited to think about how we can bring things together. And so I have a graphic here. And in fact, I think it was my desire to show you this particular picture that I decided I'd use slides after also. So I hope this is working. But sorry, Bucks fans, but this is, I'm from Chicago, okay? Now, you stop and think about it. I'm sure probably everybody, and by the way, I'm also a Packers fan, okay? And when it comes to football, go Badgers. But here's my basketball loyalty up here. Now, if you stop and think about it, you could not find three more different people than Pippen, Rodman, and Jordan. You just couldn't, okay? I mean, how Scotty and Rodman got together is just beyond belief. I mean, y'all remember those personalities? Okay, if they had been put on the team, it would be like the internists, the surgeons, and the orthopods. I mean, they're at war with each other, or the invasive interventional radiologists and the OBGYN who have increasing modalities. I mean, the war would exist, right? And that's pretty much what we've got with health reform today. We've got all these competing interests that get paid by Medicare and Medicaid just to bill. Great topic that's already been well developed, not only yesterday in discussion by my good friend and colleague Kevin Fickenshire, but increasingly we're aware of that. So this is, does this look like a medical staff at a hospital? Not Agnesian, I understand, but maybe another hospital somewhere around the lake or something like. You can relate to that one? Okay. Now, how did this gel into a wonderful team? Here's a metaphor for health reform. I think that the genius of the Bulls teams of the late 80s and the early 90s was Phil Jackson. Everyone thinks it was Jordan, but no, it was Jackson himself, a former NBA player, who knew how to coordinate these different personalities and bring them around a common goal and get them to think of winning a game as opposed to being the person that got the most points or got the first triple-double or whatever. Didn't care what the Bulls did. Okay, so it's a team effort, and that's what we need. We need not only to bring our different medical, look at this not just as three different medical specialties, but as physicians, nurses, and pharmacists. Look at it as hospitals, medical groups, and insurers. See, we're all at each other's throat. But it takes somebody, and this is what we're looking for. And there's nothing in the Health Reform Act to create the leadership that can bring these people together. I was so excited to learn that Marian actually has a doctorate in leadership. You're pretty much unique in that. I mean, I don't know many. And that's what we need, is leaders to go out there, people who can envision it. So you don't have to be a graduate of Medical College of Wisconsin or University, medical school in Madison. You need to be a leader. And I think that the people most likely to emerge into this role, interestingly enough, are physicians. The people that have really led the country in doing neat and different things tended more often than not to be people with MD degrees, but it's not written all over that you have to be an MD. But remember this graphic, okay, just as you remember the one to look somewhere else, not just at the reform. Remember this one too, because we need the teams, and we know from the fact the Bulls could do it. Now, anybody want equal times to anything about the Bucks? Okay, I know I'm, as I say, you should have introduced me and now for something completely different, so I'll pause. Okay, I'm not going to give you time for the Brewers, but okay. Uh-oh, now I'm in real trouble. Yeah, I live in the shadow of Wrigley. I can't help it. Okay. But, uh-oh. My evaluation is just plummeted. Can I quit? No. Yeah, I got to redeem myself now. Okay. Cubs just might, no, I shouldn't go there. Okay. The foundation of effective health care, in other words, is got to change, and we can't do that on the paper trail. So my second set of tweets is about the real problem that we've got with the paper trail. We are absolutely at the limits of what we can do keeping our health records on paper. And indeed, go back a couple more weeks, in both JAMA and New England Journal have articles about the complexity of evaluating all of this genetic information, coordinating it with our drug responses. We're talking about something that no human being can handle. We're talking about looking at hundreds of different loci, looking at genome-wide association studies, looking at major drug reports from trials involving patients that are taking a drug right now. It's a very complicated situation. I argue, and nobody's disagreed with me yet, it simply cannot be done on paper. So for us to actualize the new powers of medical science, we've got to get off the paper trails. So the foundation of really doing things right is going to come from shifting from paper records to information technologies. And now, that was done in February of 2009, or presumably done in the high-tech Title 13 of the American Reinvestment and Recovery Act. And high-tech, I don't know who to believe. Some people say it's as low as 17 billion, others say it's 33 billion, is available for hospitals and medical groups that become meaningful users of certified technologies. And for some reasons that I'll elaborate later in my presentation, I think that part of reform is also going in exactly the wrong direction. But I'll come back to that. But it is a premise to me, something we need to push for, has to be part of our education, part of our healthcare systems, is to be getting off the paper trail and onto electronic databases as quickly as possible, so that the data on each of us as we present to our doctors and to our nurses and our pharmacists is at their fingertips. We can look at our information. We can find out what isn't in there, what tests we might want to make sure are performed so that the people taking care of us can do the best. If we don't put that in paper so that everybody that we're seeing can look at it, we're stuck because there's only one official paper record, and it can't be everywhere that the patient can be. So we need to do it, but I don't think that the high-tech legislation is doing it in the right way. Another thing you can press me on when we're finished. But I think the best healthcare is going to be supported by integrated multi-platform networks that are dealing with digital data. And indeed, when you look at the healthcare delivery systems that were used as the good examples for health reform, Geisinger, Mayo, Kaiser, North Mississippi and Tupelo, Intermountain Healthcare, Virginia Mason in Seattle, Marshfield got a lot of it. They're all totally digital. They didn't wait for the government to tell them how to become meaningful users. They just went ahead and did it. And so we've got to do that, I think. That becomes a part of what we put together. And then telemedicine becomes very important, using the asynchronous technologies that will allow us to communicate our information to our clinicians without having to see them. And it's so 20th century to have a face-to-face visit with a doctor, to be violent. Now, a lot of people still need to have those, but so much of the information that these docs need, and maybe I've got other physicians in the audience, I don't mean to just pick on my two good general internists here, but so much of the information that they need is available from the patient's home. What do they weigh in the morning? Why not have an electronic scale that records the patient's weight each morning and starts speaking up if the congestive heart patient hasn't stepped and measured his or her weight? Such scales exist. With our patients that have diabetes, why aren't we using the many cell phones that are available to prick the finger, assess the hemoglobin A1C, and put that into the medical record? That's what telemedicine is all about. And we've got to use these virtual visits because, quite frankly, and this has been an absolute common theme of the conference since yesterday morning for those of you that haven't been here, is we don't have enough primary care practitioners to have all these visits we need. One of the things we've got to do is start using more more technology that can be in the home, can be worn on a belt, to do the things that we used to do way back in the 20th century in the doctor's office. We don't have the doctors, we don't have the nurses in the offices anymore to do that, so we have to change. We also need to have the digital data systems for real-time comparative effectiveness research to do the things so that when you have a system in Agnesian or any of the other systems around, it would absolutely be large enough. At any given time, if everybody's singing out of the same hymnal, everyone's using the same electronic databases, at any given time, your medical staff, your pharmacy community, your advanced practice nurses are treating enough patients with the big diseases that matter that you could be conducting real-time research and correlating it with the genetic differences in their disease. But you can only do that if you're on a digital platform, as is proven by Mayo, Intermountain Healthcare, North Mississippi, Geisinger, et cetera. So we've really got to take that seriously. And then we have to use the e-health tools, the web-based interactions that allow us to transform the provider-patient relationship. And so we're doing much more electronically. Just let me walk through a couple of these. This is so common now that virtually every newspaper, this one from the New York Times, has reported lately something about how many doctors make virtual house calls. And the doctor will see you now, please log on. This is not an aberration anymore. The doctors doing this all across the country. Doctors prescribing online. Doctors actually being required to treat patients. And I find this absolutely fascinating that two West Coast organizations, Group Health in Puget Sound and Kaiser Permanente, actually all across the United States, are now, as this little thing says, requiring their doctors to have a certain number of their patient contacts be virtual. At Virginia Mason, one of the 20 or 30 health systems that got constantly identified as one of the best in the U.S., or excuse me, at Group Health Puget Sound, Virginia Mason and Group Health were both there, Seattle had two. The doctors are up to about 30% of their interaction with their patients now electronically. It can be done. And so we wonder, where are we going to find all the primary care practitioners? We're going to eliminate the need to have them seeing patients so often and get down to this. Kaiser Permanente just put it in its requirements for all of its doctors who are salaried employees that starting February of this year, they must have 5 patient interactions, fully documented patient interactions per week with the population they're serving. Can be done. It's really exciting stuff. The do-it-yourself house call, using the technologies so that the doc can communicate with the patient. How many of you Skype in here? Okay, well, imagine Skype as, the alternative for you. And you might say, well, I want high-touch healthcare. Well, that's high-touch. That means the doc cares about you and is keeping up with you more actively than he or she might be able to do it if you had to keep coming into the office where they're absolutely strapped. And remember, it wasn't that many years ago that the Bell system used to say, reach out and touch someone. We already realized that touch can be something we do by communicating, not necessarily by tactile response. Then just a host of websites that will help us, in this particular case, price services in advance. Feed our symptoms into the system. There are dozens out there that will tell us what are all the alternatives based on our lab reports, our symptoms and the like. And then, again, dozens of websites that will help us manage our health. Many of these run by Mayo Clinic. A Cleveland Clinic is probably running these. Hopkins runs these sites. So we're not talking about something done by a fly-by-night pseudo-practitioner from South America or something, okay? Now, the third thing that's very important to recognize when we look at the new possibilities for healthcare is the ongoing changes in the American population. We are going to be treating a very different population. The people that will consist of the majority of American patients is becoming something very different than it was back in the 20th century. And indeed, cultural, racial, and ethnic diversification in this country is absolutely phenomenal. The demographers only disagree whether the sum of all minorities will exceed 50% in the early 1930s or the late 1930s. In other words, we're moving to a country with a whole new genetic, cultural foundation of its healthcare problems. And I'll show you some slides in a moment to make that point. We're seeing a dramatic increase in infectious disease, behavioral problems, environmental conditions. The Journal of the American Medical Association just last July devoted the entire July issue to articles about pediatric conditions that were associated with global trade, with new things that were coming in like lead paints on toys, foods that had been tainted by bad things that were made in other countries, that were things showing up in doctors' offices. It's all brand new, but it all comes from the fact that more and more Americans are eating foods that came from other things because that's their cultural other countries because that's their cultural heritage. And then the pharmaceutical therapy, as already mentioned, I think is going to rise due to all of these changes in disease patterns. But if you were in my class, and ask anybody that had me as a professor down at Madison, they'll say that there was a way that my voice emphasized things a little bit. So if you were in my class, you'd hear that emphasis on this slide. In other words, this could be on the test. The red line, the line on the bottom, is people born in the United States before 1970 and their children. So that's who we're used to dealing with. That's the typical Agnesian patient, typical patient for the good doctors from the group here, what have you. The blue line is people born outside the United States since 1970 and their offspring. So in the last 40 years, we've actually seen all of the net, in fact, since about 2007, 2008, all of the net growth to the United States population above a base of about 243 million is people born outside the United States since 1970 and their offspring. And somewhere in the 2030s, that will be more than half of the American population. That's stunning because now we look at the genetic information. When I taught epidemiology at CU Boulder or CU Denver, where the medical school was, oops, I'm sorry, I got a little ahead of myself there, and down at Madison, we just taught people what we knew then. Asians had higher cancer rates. than Anglos. Okay, so if you had an Asian, you might assume there was a slightly higher probability. But now we can look in at the genes and discover that the cancer rates vary dramatically. If, for example, you're talking about liver cancer, it's 4 times more prevalent in Vietnamese than it is in people from Japan. Okay? We've also learned, now that we can look at the genes, that men from Korea do not have the enzyme to metabolize SSRIs, selective serotonin reuptake inhibitors, which are arguably probably the most common class of drugs used to treat people with depression. So think back to that tragedy a couple of years ago at Virginia Tech, where the Korean student shot a whole bunch of people, and everyone was very critical of the university because it had discontinued its treatment. Remember, he had been going to the student health center and taking medications for his depression. They discontinued because he wasn't showing any response. A month after he did that, the research studies were published that showed that 90% of all males with Korean genes do not have the metabolite that allows them to get any benefit whatsoever. It just goes through their body. They don't process it. Okay? These are the phenomenal things we're now beginning to understand. It informs clinical decisions. So look at this cartoon. I love this one. It's probably monkeypox, SARS, or the West Nile virus. Well, that cartoon appeared in 2003. It could not have appeared any earlier than 2003 because that's the first year monkeypox, SARS, and the West Nile virus were in the United States. So we've got all these new diseases coming in, new genes. It's a pretty exciting time. Okay? But And this is what we need to be thinking about when we build our new healthcare system. It's look over there and not look at health reform. Now, the new approaches to the payment for care are going to create major changes in the supply and demand for care. I can go through this pretty quickly because lots of other speakers have addressed this. I think I'm the first person to talk about what we've addressed so far. But government-directed health reform is going to continue to be a major political problem. I mean, the government just crammed some stuff together on a Sunday morning. Bart Stupak called Nancy Pelosi and said, if we have the vote tonight, I think I can get you 8 votes. Excuse me, I think I can get you 18. He only delivered 13, but it was enough to finally have the House pass health reform. I mean, it was just amazing how they threw stuff together at the last minute just to get the votes because Ted Kennedy had died. It was a Republican replacing him. And so don't think for a minute that the health reform bill was a well-crafted piece of legislation. You might remember 1 week and 3 days before the vote, President Obama had been on television, and he had promised to the American public that because Newt Gingrich had asked if anybody had read the Senate bill, and not a single senator said they'd read it before they voted on it. So Obama, our president, got on the tube 10 days before the vote and said, the House will not pass a law until it has been online for everybody to read for 3 days. Remember that? It was not put online until 7 months after it was passed because people were pulling out little slips of paper. What did we say? What was in there? I think that's an absolute record for the enrolled law going into the public. Usually they come out within a week of the time Congress acts. So it was a mess. That's what, if you wonder why things are not working out so well. But I think the key, no matter whether it's a good law or a bad law, the key is that people are going to be expected to pay more for their health care. That's really what's embedded in the health care reform. And I had this brought home in spades when I wrote an article that is included in the packet that you can access on the website for the Healthcare Financial Management Association's journal. And I talked about what really health reform was doing was moving from the United States where 84% of the people had health insurance that on average paid about 78% of their bills. So 84% of all Americans, either by virtue of Medicare, Medicaid, or insurance through employment, were insured when the health law was passed last March. 84%. The sum total of all those bills paid about 78 cents on the dollar of their health care. And that's called the actuarial ratio. Okay, the law that goes into effect in 2014, in the unlikely event that it's ever implemented, I think it's such a mess that I've got a lot of reasons. If you want to discuss them, it's fine with me, but I don't think the chances are very high that it's going to be implemented. But if it is, it's going to impose Americans to buy. It admits that a lot of people are still going to fall through the cracks, but the presumption is that 94% of the American population will have health insurance. And what is the dirty rule? Actually, it wasn't covered up at all. You just had to look for it. The actuarial ratio is going to drop from 78 to 65%. So if the law is implemented, we're going to have more people in insurance. Great, reform was a success. And they're going to be expected to pay 15 cents more on the dollar, roughly, for their health care. Now, how many of you think the economy is going to turn around that quickly? How many of you expect to see the end in the absolutely abysmal redistribution of income in this country toward the wealthy? As critical as I might be of health reform and the law, I am more concerned by the fact that we will, over the next couple of years, with or without reform, quite frankly, transfer a much bigger portion of the responsibility for the bill to the patient. We had several people at the panel that I chaired this afternoon, I think, making that point quite well, at exactly the time nobody has any spare cash, unless you're rich. And we now have the situation in the United States where 10% of the people in the United States control 75% of the assets. And it's getting worse. So I think we have a social cataclysm on our hands as we're expecting people to pay more and more of their health care bill when they can't afford their mortgages, they can't afford their food, they can't afford their gas. Everybody with me on that? That is the disaster built in. That's the smoldering volcano, in my opinion. But we need to be doing something about that. And that's a good thing. That's why I'm so glad programs like this have ethical issues and the like. I think the big problem is not lack of insurance. I think it's lack of ability to pay for health care. And so I'd much rather focus on the abysmal income redistribution from poor to wealthy in this country. That's a much bigger problem to me. Time for too long, y'all get a chance to have at me. But what I really think gets me excited and leads to my last section of this presentation, and then I do turn it over to you, is we could do some creative partnerships. We could bring people together, focus on the new medical science, the new technologies, the ways that we could reflect the changes in disease, recognize the fact that affordable care just has to be less expensive care because people are not going to have the money to pay for care. And interestingly enough, if the Affordable Care Act were really focused on making care affordable, it would include provisions for reducing the cost of care. It would help the doctors adhesion. It would help the pharmaceutical companies lower their costs of care by making them more efficient, allowing them to sell less expensive things. Anybody tell me any section of the law that does that? You can't, because it's not there. So the Affordable Care Act is sort of a misnomer, oxymoron, what have you. But all that said, and I stress again, I'm not a show for the Republicans. They never invite me to speak to them because I'm really even harsher on them. Okay? And they probably checked my party affiliation anyhow already. But if we would get creative and really imagine what we could put together here, we could do some neat things. And so I think, I'm excited about this, the opportunity to get providers, payers, and purchasers and their business partners together and say, let's start from ground zero. Let's redefine what the doctors do, what the pharmacists do, what the nurses do, how people pay for their care, where they get it. I just showed you we got all the tools to do that. So that's what excites me. But then when I speak to insurance groups, which I do rather often, I remind them, and they're not off the hook, as you'll see in my slides in just a moment, I remind them of the first law of parasitism. I learned it back in 9th grade biology, which was more years ago than I care to remember. But I do remember that I learned, don't kill the host that feeds you. I Googled it just to double check that. Shows I'm really a hip 21st century guy. And I found that actually there are two other statements in the first law of parasitism. No element of society can survive at the expense of the other elements, and protect what you prey on. Okay? We should take that to the healthcare debate. Because we're killing each other. Well, really, the health insurance plans could put the doctors, or could put the hospitals out of business. Government payment cuts could put the doctors out of business. Ridiculous controls on pharma could put the drug companies out of business. Nobody's thinking about the big system. So we have to remember this law of parasitism. And again, we need those leaders. We need that equivalent of Phil Jackson to get out there and say, let's start from scratch and use these new tools, because we've got tools to do it really well. So as critical as I am of health reform, I'm excited about the tools that are at our fingertips if we just get around to using them. But I love this cartoon that appeared right after health reform. Who are the poli-sci majors in the audience? Anybody from poli-sci? Everybody in poli-sci. I skirted with poli-sci for about 2 weeks when I was in college, and physics was wearing on me. But everybody in the poli-sci class learns very quickly that there's two things you never want to watch. Okay? One is making sausage, and the other is passing laws in Congress. And so taking, that seriously, I just love it. In fact, by the way, the day after the law passed, I have at least 6 cartoons that played on this theme. But I think this was the best one. Pelosi coming and saying, we have a bill! Oh, we do dirty things behind those closed doors, but we have a bill. But my favorite cartoon came the next day, the mail being opened at the White House. Mr. President, the sausage makers of America are demanding an apology. You one-upped them, Why aren't we focusing on the good stuff rather than all this? But what we did with health reform, and I'm not making this up. I'm a big Dave Barry fan, and I'm not making this up. All health reform was insurance overhaul. And indeed, the Democratic talking points right after Sarah Palin came out with her criticisms of the government death squads and all that stuff. The Democrats just walked away from it. And I saw a couple of their talking point things that said, start talking about insurance overhaul. The one thing that everybody cares about is they can't afford their insurance, so they get shafted by their insurance. So what reform really does is it takes insurance and puts a new face on it. Now, these are the cars that, I mean, 64 Mustang, man, that's my senior year in high school. A 57 Chevy, that's what the seniors drove, you know. These were cool back in their day. Now, I had downloaded these probably about 3 months ago from the web. These are both for sale. In fact, I think that the Chevy is for sale in Green Bay, or was, I don't know. But boy, don't these look slick? Now, would you want to drive one of these? Try it. Do you think you can pay the insurance? Think again. You know, remember what kind of mileage they got? 7 gallons per mile? Remember that? Remember how unsafe they were? Ralph Nader wrote a book about, you don't want to be in a wreck in one of these things. Remember what clunkers they are to park? Remember how expensive they were, the mechanics? You know, these were over-engineered marvels that no human being could understand. So we look at these and say, wow, those are beautiful. Is there any one of you in here that drives one of these every day? No, they don't hold up to today's cars. We've moved automobiles, transportation in totally different directions. So this is what we got, is overhaul, a new insurance product. I hate to quote Sarah Palin, but she made the statement about the pig, the lipstick on the pig. This is what health reform did. It's just taking 20th century healthcare and trying to make it more affordable. Now, from my ethical point of view, that's not moving us forward, especially when we've got these better opportunities. So here are the take-homes at the end of environmental assessment, and then I'll lead into my last session and be done. The delivery system is going to have to change. The economic system, the economic circumstances we got today, going to compel us to reduce the expenditures on healthcare. The survivors are going to be the health systems that learn how to do that, and they're going to do that in spite of health reform. But we're going to discover healthcare becoming more national and less local. I don't like that. I happen to believe healthcare is better when it's local, but don't think for a minute that the Mayo Clinic and the Cleveland Clinic and a lot of national organizations haven't started to look for patients in Fond du Lac, Wisconsin, and the big clinics around lakes to the north and stuff like that. They're discovering that they've got systems, they'll have the numbers to show that they're not bad places to go, and then we have this whole international tourism, medical travel kind of thing. Suddenly, people are discovering that since you can't afford care locally, if somebody can give you a top quality service for half the price of what you'd pay for it at home, even with insurance, you're pretty likely to get on an airplane. And so we're going to see our providers feeling pressure to become accountable for value. I'm not going to explain this at all. It was very well developed in both the panels today, and I know Kevin talked about it last night. And that's the whole idea of giving people the best possible bang for their buck in healthcare, and we don't do that at all well in the United States today. And so what we're going to find is that providers and practitioners are going to need to align their financial interests, bring everybody under the same balance to begin doing these new things called accountable care organizations. Now, the law includes regulations that are going to come out for accountable care organizations. And I don't like accountable, I guess if there's something nice I can say, I like accountable care organizations. I think they're highly desirable models. But we can't afford to wait for the government to define the regs. And it's interesting, the idea of doing accountable care models came from studying what was being done at Geisinger, what was being done at Virginia Mason. So the proof of concept is already proven. Why the government is setting us back 6 or 7 years when forcing healthcare systems to sit back, well, let's see what the government regs are. No, just see how it's being done and move with it. Don't wait for the government, because you won't have that luxury in today's economy. And I think American healthcare and the national economy really are heading for a serious problem. If we don't deal with this now, and interestingly enough, the demonstration projects for accountable care are expected to be awarded in 2012, and the reports will come in and be implemented in 2017. Any health system that waits for 2017 to see if that's a winner, I'm very public on this thing, I think has a 1 in 4 chance of being bankrupt, because we've got all these other problems that are going to intervene, so it's pretty significant. So what are the things that the providers and the payers and the purchasers can do? My particular conclusion is we've got to become efficient. And I won't give you an economics lecture. I'll just tell you that, how many of you remember the U-shaped cost curves and defining efficiency, where they came from the bottom of the curve or the top? I'm not going to do that. What matters is that to an economist, efficiency means there's no waste. When you're right on the curve, every penny you spend is going into the product that you promised, and it's a productive product. So we have to become efficiency. And that means maximizing output for fixed budget and minimizing costs for fixed output. But it means getting rid of the waste. Now, do we have waste in healthcare? Okay? You probably don't here in Fond du Lac, but at a stone's throw away somewhere around one of the lakes, we have waste in medical service. Of course you got it here. In spite of our best efforts, The studies show unambiguously. And when I wrote Paradox and Imperatives in Healthcare, and I got about a month and a half into the project, I said, geez, I need a researcher. So I brought in a co-author, Mark Haglund, who's a very well-known journalist, and he's from Milwaukee. And Sister taught me how to say that right today. And did I do okay, Sister Donna? Yeah, no L in it, okay. Mark is just a superb researcher. He's the editor-in-chief of Healthcare Informatics. He's probably written more healthcare articles than anybody alive. And Mark did the research for me, and we found about 40 peer-reviewed published, solid studies that showed unambiguously that the range was between 20 to 35% of every dollar that goes through a healthcare delivery system is totally wasted. In no way can it be tied to better health, to reducing costs of care or anything. It's money spent in healthcare. And so what do we see in the way of waste? Additional services necessitated by incorrect or unsafe practices. At the panel this afternoon, 2 of the panelists spoke about the fact that you're not going to get paid in the future if you didn't do it right and the patient has to come back in too soon. The government has already compiled a list of never events. I think it's up to 11. Do you docs know? Yeah, I think it's 11 events. And I'll tell you, if you leave something in a patient and sew them up, or if you give them a hospital-based infection due to removing a catheter incorrectly or whatever, don't bother submitting the bill to Medicare or the other, because they won't pay you. They said, you screwed up, we're not paying for those errors anymore. And so as we look into that, we discover there's an enormous waste. And so I will take axiomatically, as sort of an average of all the literature, that 30 cents of every dollar we spend on healthcare right now is doing nothing to contribute to a better patient outcome. It's just money down the tubes. It's using unproductive or counterproductive clinical interventions, continuing to prescribe drugs that have been shown for years in the literature to have no efficacy, continuing to do surgical interventions where it's very clear that exercise gives at least the same outcome. It's continuing to use stents for patients where the research is now super clear that after 1, 2, and 5 years, whether you have a stent or whether you use a medical approach, what the internist can do, your outcomes are about the same, and yet the medical course over that 5-year period is about $10,000 total. The cost of providing the stent and the follow-up care is about $27,000. See, so we're using the expensive service. We shouldn't be doing that. We're using care that's inconsistent with the current evidence, another topic that was addressed quite amply in earlier presentations. Failure to use the least expensive resource to achieve the desired result. Using a radiological study when the indicator could be picked up by a simple blood test, or using, say, an operation on the back when massage therapy proved to be just as effective. Poorly utilizing our personnel and facilities. When you look at how much time doctors, worth arguably easily $100, $150. I mean, any doc's time, I as an economist can prove, is worth $100 to $150 an hour. And you look at how much time they spend looking for information that could be delegated to somebody that earns $10, $15 an hour. Does that ever happen in your office? I'm sorry, I shouldn't pick on them, but so I'm hoping my son will go into general internal medicine, so obviously I have a warm spot in my heart for these fellows. But the time that we waste because we don't have electronic access to information. The redundant reimbursement procedures, as I said a moment ago, the carriers, the health plans aren't off the hook at all. They make you jump through tons of hoops, and they hook you and things like that. It's ridiculous. They are a big part of that waste. A big part of it. And they've got to also, as I say, remember the law of parasitism. And then the inappropriate balance between acute care disease management and prevention. We wait until people have these expensive diseases and try to solve them, when we're learning now how early it is to identify in advance the people that are at risk for certain conditions and start treating them now. Forget cure, manage, and we'll save a ton of money. People will live longer, be happier and healthier, and we'll have a really good healthcare system. So what else can the payers and the providers and the purchasers do? I think they have to replace their traditional operations, not only becoming efficient to cut out the waste, but also to become effective. Now, do we have any economics students in here? Okay. Do you have an econ major, or they just don't come? Oh, you don't have, then, okay, there's,
we have finance.
You have finance and econ, okay, cool. All right, and then I'm an economist, so I was hoping to meet a few of those students. But efficiency is a dollars and cents thing. Effectiveness is how well you produced what you said you were going to produce. Okay, so if you, there must be some company around here making gears, because I flew into Milwaukee yesterday with some guy that was driving up here to a company that makes gears. He wasn't coming to Fond du Lac, but it was north of Milwaukee. I think Sheboygan, someone who's coming up to make gears, And I can guarantee you the people that they sell their gears to, they're sending them back if they don't comply down to the millimeter, in terms of strength and everything. They only buy products that meet certain standards, and they test things that come to the loading dock, and if they don't get what they paid for, they send it back. Well, that means they're only going to buy effective products. Well, in healthcare, boy, we've got all this waste, all these things that we do wrong. We got a problem. So we need to begin measuring the extent to which we produce the changes in a patient's health that we said we wanted. And again, hats off to the people that put together this program, because at least 5 or 6 of the previous speakers have talked about the ways that we can begin to measure things, to become accountable, to have the data available. In fact, in the panel that I chaired this afternoon, I think several of the speakers made it very clear, we really know that those data are going to be expected, so we're going to be held to accountability. We need to define in advance what the results of our interventions are going to be, how we're going to do it, and the like, and that becomes very important. And yet, I can tell you, and that's why I wish I had it, one of your finance or economics majors here. They know if they're juniors or seniors, they had this in texts already. But if you have limited resources, you have hit the limit of what you can spend, which I think is where we are today. We're not going to be spending any more in healthcare, anything else. We don't have more money. The economy is in absolutely long-term stagnation. So now we have limited resources. Well, anybody in business or finance can prove to you that when you have limited resources, you can only maximize one variable in a system. So even though I'm here standing in front of you saying we need to become efficient, we need to cut the waste out of the system, we need to become effective, we need to say here's how good our care is going to be, and then actually deliver care that's good, we have to make a choice. The only thing that would allow us to be able to say we're going to become more efficient and more effective, optimally efficient and optimally effective, say we're going to see 20% of GDP go to healthcare. It'll be 25% in a decade. It's not going to happen, folks, because the money isn't there. So we have to make a choice. And I'm going to put in a little editorial comment here. Here's my choice. You don't have to agree with this choice, but I'm here to tell you if you start getting involved in trying to build a really good healthcare system, you have to make this choice. Here's mine, and it's the only paragraph I'll read you from the book. To save money, would you be willing to get your healthcare from a provider that publicly admits its care is not always as good as it could be? Think about it. Now, embedded in our health reform law is that if you're going to get, and in the high-tech law, is that if you're going to get these government premiums, you're going to have to meet the quality standards. Well, as several of the speakers have already said, so I don't have to have anyone bear witness to me on this, the quality standards are all 80%. 80% of our patients that show up in the emergency department get aspirin within 4 hours. 80% of our patients that come in with respiratory problems, we find out if they're smokers and tell them to quit smoking. And you're down the line, we're up to about 60-some quality indicators now, I think. 107, they keep proliferating faster than I keep, But now, stop and think about it as a consumer. Hospital puts up a thing and says, hey, we need all the quality indicators. We do it right 80% of the time. That's not bad, given that the averages still, according to the latest surveys, are down around 68, 70%. So the people that are doing 80%. But come on, can we do better than 80%? We're the United States of America. We got all these technologies. Of course we can. So, go on. My wife wrote this next sentence. Most people wouldn't be any more willing to patronize this hospital or medical group than they would be to fly on an airplane that admits gets you, not just your luggage, to your destination most of the time. See, that's what our medical standard is. We do it right most of the time. 80 times our economy. We can prove to the government we're going to get our 2% quality hit kick because we do it right 80% of the time. I'm not flying on that airline. I'm looking for a healthcare system that does it right all the time. And they're out there. They're in Wisconsin, for crying out loud. They have the data, they have the procedures, they have the responsibility of their employees. It's not magic rocket science to have performance improvement, to do ISO 9000 stuff, and to really begin making sure that errors can't occur in the medical system. And there's some systems in this country that are doing it pretty darn well. So what I'm arguing, Mark and I argued in the book, is that the statement that we ought to expect of our healthcare system, this is my vote, you can go the other way, but we ought to expect of our healthcare delivery system, doing it right all of the time, as inexpensively as possible. So in other words, I think quality is number one. I dream of a healthcare system, and I know it's possible today, and we don't need a government program to do it, to get our acts together, to have the data systems, the accountability programs, the informed, educated, empowered employees say, hold it, let's stop. This is not proceeding the way it's supposed to proceed when we do this operation, when we follow the patient with this disease. We can do that. That's what performance improvement is all about. Now, this is really my last couple of minutes here. When I was writing the book, I live in Lincoln Park, and one of the reasons I love living close to the lake is I'm an addicted runner. I can't not run. And I'm hoping my knees just keep going for me. But so I'm writing this book fall of 2007, you know, and really trying to. And now, how many of you remember back to fall of 2000? What was the culprit in the United States? It was the SUV. How many of you were afraid to, embarrassed to drive your Suburban to work the summer of 2007? Remember that? Because it was getting 9 miles a gallon. Gas was $5 a gallon. Remember all that? The safety studies came out and actually showed that SUVs had worse safety records than subcompacts. Remember all that? Like, sort of like those rehabbed, overhauled cars. So remember, and by the way, with gas rising again, if you happen to have an Expedition or one of those Texas Cadillacs, you're probably going to be a little embarrassed too. But I'm running through Lincoln Park, and I see this, and suddenly, again, I told you I'm an artist. I'm very visually oriented. Another reason I wanted to go with slides when I started thinking about it. So this is healthcare. Healthcare is SUVs. We have to begin thinking of other ways to get there. And so, what do you think that we could get around Chicago with scooters and smart cars, and have a few SUVs for when we really need that, but having everybody have an SUV when you can get 100 miles a gallon or 65 miles a gallon and get there and just reserve the SUV for everybody with me on that? This was my metaphor for healthcare. Healthcare has to begin to think of doing this. Now, it would be unfair if I left you with the impression that I'm brilliant and that because I'm an artist in my other life I can. No. Let me show you what I actually saw as I was running around the lake that day. I'm charging along, and this is in the marina at Diversey Harbor, right by where I live. And I'm actually timing myself, getting ready for a race. No, I ran home and got my camera and just prayed that they wouldn't move those things. Is that an instructive photo or not? Yeah, that's what we've got to start thinking. And we can do it. We have every technology, we have every capability, and I don't find reform moving us in that direction at all. But I come to a university like this, and I find you're teaching the people the scientific skills that they need, the technical skills. This is what really exciting. So we need to begin thinking of having the least expensive way to get what we need, but doing it right all of the time, and that's pretty darn exciting to me. So, what can patients do? The last slide, and then I show you one more graphic, and the rest of the evening is yours. What can patients do? Because I got to be part of a radio show, and I was on air with Professor Ayala and a couple of the students who were really savvy, and we were talking about trying to get some people here from the community. What can you do? Well, first of all, I hope you will join me in thinking of the system, but I think you've got to get active in your management of your own health care. We can't sit back anymore and wait for Advision or Dr. Ayala or anyone else to take care of our health care for us, okay? The abundant evidence that you have heard if you've been in this room for the last 2 days is just speaker after speaker talking about how much we can know about our own health and how many things we can do. So that's really what health reform, it starts not just at home, but it starts with us. And that means not expecting the system or the government to improve your health care. There's nothing in the health reform bill that's going to make you healthier. It's just shifting more responsibility to you as it mandates insurance. I am sorry. You all have opportunity to harass me in a moment if you see it differently. Get and stay healthy. Really exciting. And we've seen example after example for 2 days here of your students right here at Marian learning how to keep people healthy. I would say more questions have come up about health promotion and disease prevention than any other single category of question in the last 2 days. Is that a safe statement, those of you who have been here? That's exciting. Shows we're aware. Now we need to start making our health systems support what we all know we need to do. We need to ask questions and be informed about our options. Go online, have a health coach, have symposiums at the local college and go out into the community and talk about the options that are available. That gets me really excited. And then become involved in our decision making. As there are more and more options and as more and more of the care decisions relate to our very own pocketbooks, and believe me, several of the previous speakers have talked about rationing. In fact, I thought the most eloquent comment was from Dr. Myrick? Merrick, okay. He had a quote, he says, it's not an issue of whether we're going to ration or not, it's whether we're going to do it well or not. And that's absolutely right. And whether we ration well depends on you as consumers being involved and working with your doctors and your nurses and your pharmacists to find out what options are available to you, what changes could you make. That's where healthcare, and primary care, probably the biggest single conclusion you could draw from our 2 days here, is where it's going to happen. It's going to happen from giving more resources to the teams that can work with you as individuals to help you get healthy and to be supported so that you're managed rather than becoming that. But my last point before I move on to my last graphic here is what you can really do is imagine a great healthcare system. Start imagining not putting lipstick on the insurance pig, but rather start imagining how could we use all these tools to develop a good healthcare system, and then get involved in building it. And that's why it's so neat that Marian put this together. Well, my last slide, and then I'm done. I gave a speech very similar to this in May of 2010 in Brussels, Belgium. And coincidentally, being an artist, I wanted to see what was showing at the local art museums. And as luck would have it, the Belgian government was just opening a museum to René Magritte, the most famous 20th century Belgian. How many of you recognize Magritte? You know, I mean, he's really super artist. And for the cover, the people that run the museum chose this graphic. And so, although I'm excited with several of the other graphic images, this is the one that I hope becomes embedded in your thing. Imagine a great health system. Don't assume that the government is writing a model of what you have to do in Fond du Lac. Rather, use the neat ideas that have come out in this conference. Whoops, I'm sorry. Look at that egg and see what you can do. And you can do it because the people in Seattle did it, the people in Danville, Pennsylvania did it, the people in Salt Lake did it already, the people in Tupelo, Mississippi did it. And I could go down the list of the 25, 30 healthcare delivery systems that are doing it right all of the time as inexpensively as possible, and not a one of them waited for the government. In fact, indications are not many of them are planning to get any money from the high-tech law either. They're already so far beyond it, it would drag them back to get into the government plan. But we've got the tools. You have a wonderful resource. You have a neat community. I've worked here before. I really appreciate the healthcare that you've got. But the thing that would excite me the most, and as your president of your state hospital association said today, you got all the pieces in Wisconsin. You really do. And so just think of this bird and how you could fly here, and I'll enjoy coming back to Fond du Lac over the years and watching the neat things you're doing. Thank you very much. And I owe you an apology. I intended to make that 1 hour to 1 hour and 5 minutes, and it went 1:15. So I'm pretty excited, but you're good potential there. Questions, alternative points of view. I pause and allow people to make eloquent statements contrary to everything I said, and you may be right.
Dr. Bauer, we've got microphones on either side here, so if you have a question, please raise your hand, and we'll bring down a mic so everybody can hear your question.
Okay.
Hello again there, Dr. Bauer.
Yes. Good to see you again.
Same to you. I asked this question last night, and I'm curious on your response. Considering all the changes that are happening, have there been any lessons learned from international healthcare systems or the transformation that international healthcare systems, such as those in Canada and the EU, have gone through in the past 50 years that are being implemented in the United States at this time or are included in the healthcare bill that are making this transition easier?
Excellent question. I find it interesting that you choose the two countries that I think have amongst the best healthcare systems in the world, and I'm not alone. There are two international ratings, one from the World Health Organization and one from the Organization of Economic Cooperation and Development. And both the WHO and the OECD rank Canada second or fourth, and England third and sixth. Top 10 health systems. They are very, very good healthcare systems. But they are, they're quite frankly, government owned. I mean, the doctors work for the government. The hospitals are owned by the government. And I simply cannot imagine that happening in my lifetime in the United States. So there's a social difference between Canada and that. It's called, for those of you that are historians of health, it's called the Beveridge after Lord Beveridge, who was the Prime Minister of Canada in, of England in 1948 when they created their national health system. And Beveridge made eloquent pleas that any good country takes care of its people. I happen to agree. And in fact, there's an awful lot of me that would fit better if I lived in England or Canada, but it's not the way it is, and I'm proud to be an American. But that was based on political motives, that it was okay for the government to own everything. And indeed, to this day, the governments own most of the education institutions. Most of the people that work in public service are government employees in both England and France. On the other hand, you have what are called the Bismarckian systems in Europe. And those are Germany, France, Switzerland, Denmark, and several others. And France, by the way, which is pure Bismarckian, ranks #1 in both the WHO and the OECD. And I've lived in France for 3 years, and I have a lot of good friends in France, so I'm pretty familiar with the healthcare system, and it is an awfully good healthcare system. I feel it's defensible that it's at the top of the list. And that's based on Bismarck's idea that it was a social responsibility to allow the private sector to move the resources. So today in Germany and in France, the government, and in several other European countries that rank in the top 10, the government sets the rules of the game. The government doesn't own the hospitals, the government doesn't own the insurance companies, but the government tells the hospitals that they have to meet certain qualifications. The government tells them how much they can spend, but then lets them decide how to spend it. This is the fascinating. The French government each year determines how much can be spent on healthcare the next year, and they've pegged it at 12%. So I argue that what we should do in the United States to learn from France is peg our healthcare spending at 17%, and then let's beat the French and show how good you can build a healthcare system for 17% of the GDP. They spend 5% less, 12% of their GDP, and knock our socks off in every category you can imagine in terms of health. Okay, so what we really need to do is learn the lesson. There's a lot we could learn from Great Britain, but we just don't have the social history to do that. But if we looked at France, Germany, Holland, Holland has a great healthcare system, is in the top 5 in both of those. And that's private insurance companies, private hospitals, but the government says you have to meet these needs. A fascinating hospital. I visited in Belgium when I was there for that trip. I have a good friend who's a radiologist and the present chief of staff, same as Dr. Merrick here, just finished. He's the chief of the hospital at Imelda Hospital in the northern Brussels suburbs. And I asked Jan if I could come up and see this. He's been raving to me about this hospital. It's a 525-bed hospital. Okay, it's the size of something you'd expect to find in Milwaukee. Excuse me, got to get it right now that I'm sensitized. And 520 beds, 525 beds, and it's full almost all the time. Can you all imagine? I mean, that's an academic teaching center in this country. Okay, or it's an Aurora Hospital, or probably Marshfield. Marshfield's maybe a hair more than that. Am I correct? I've been in their hospital a couple of times. But 525 beds. That's a big hospital. Okay, and Jan, my friend, who's not only chief of radiology but past chief of staff, says, well, let's go show you our imaging department. And he'd been sure I'm saving this for years. So I went to the imaging department of this 500-bed hospital, 525-bed hospital. He says, let me show you our MRI. And because we were speaking French, there's a difference between plural and singular. Here you'd never notice that. He was clearly talking singular. So I'm wondering, come on, it's 500. How many MRIs would you find in a 525-bed in a U.S. hospital? 3, 4, easily. Anybody care to challenge me on that? CT. He was using the singular of, you come see our CT, you know. Huh? 520? There's CTs running all over their hospitals. There's one in the ED. There's one up in gas. You know, they're all over the place. There's one in OB and ortho. You know, and he's telling me they're running 525. Well, they are. Now, why does Belgium rate very highly, especially on the expense? It has very healthy people, but it also has expense. And this is a lesson that we could learn, and then I'll turn it back to more Q&A. Is he showed me that they have one MR unit and one CT. They have the state-of-the-art. They have 64-slice CT. They have a 3 Tesla. I mean, they got the state-of-the-art, but they have one of them. And what they decided is they looked at the United States. They came over to RSNA all the time, and they'd find all these hospitals that were charging a phenomenal amount for diagnostics. And they said, we can't get away with that because the government regulates how much we can spend. We've got to come less expensive. So what they decided is to get one of each unit, to have full-time dedicated maintenance there so that, you know, when the machine's down, somebody's looking to make sure. They maintain it as well as our airlines maintain our airplanes, okay? And what I found absolutely fascinating is they do as many procedures as we do in a 525-bed hospital, but they are so efficient that when a patient is done with a CT or an MR study, the patient came in from the right side of the gantry, there's a crew that takes the patient off the left. At the same time the patient is being removed, the cleaning is being done, and another patient is coming in. The downtime between patients is 45 seconds. What is it here? Minutes. Okay? To meet the needs of the outpatient community, they take people that come in and they schedule during the daytime hours. Hospital patients are there stuck anyhow, so what they do is they figure, based on doctor's orders, how many inpatient studies are going to be needed, and then they have flexible techs that come in, and the tech could start as early as 3 o'clock in the morning and go through 7 doing the hospital patient studies. When we keep our patients awake anyhow. How many of you go to a hospital? Yeah. And then the community comes in and uses the MR and the outpatients and all that during the day, and then they pick up with the inpatient studies again, and the machine is on average down about 4 hours, generally from about 11 p.m. to 3. Okay, one machine. Their costs per study are a third of what ours are. Why? Because they get much better utilization out of their equipment. And everybody's using a machine that has the capability that can be, so that's what we can learn from European systems. Maximize the amount coming in, fix the reimbursement system, move more money to primary care, and then start thinking efficiently and getting by with one MRI instead of 3 or 4. It's a scooter, not a SUV. Did I miss the point of your question? Okay. You can do that here in Wisconsin. I know that. I mean, I've spent several proud years here. But I miss Wisconsin. I really do. Please, yeah.
The president did give a speech maybe about a month ago telling states they could opt out of the health care plan, I believe, if they can do it better, yet meet the basic regulations of the health care plan. Isn't that Bismarckian?
That's an interesting question. It would depend on the state. If it were Massachusetts, it would be different than if it were Wyoming. Yeah, it's effectively right. No state owns the resources, but some states such as Massachusetts, Maryland, we always just talk in Massachusetts, but Maryland is the state directs as many of the resources as it does in Massachusetts. On the other hand, we have states like Missouri that have 74% of the voters went to the polls in Missouri last November and said they refuse to participate in it at all. They're not going to ask for a waiver. They want nothing to do with it. So because of the diversity in the states, yeah, you could probably find a few, but I think overall it's probably going to be a Bismarck approach. But the president's offer of letting people opt out is just one more example of all of the problems that are being encountered. The Department of Health and Human Services Secretary's Office, I got the official count on this, issued over 3,000 waivers from compliance. And, pardon? Including McDonald's. McDonald's is one of the first. Yeah, as they said, all right, if this reform is going to hurt you, we'll let you off the hook. Okay? So, yes, the president did say that, and but he's got to skirt around the fact that, remember when he started pushing this, he said, you'll be able to keep your health plan, and if you turn it back to the states, they can make sure you can't. So it's ironic. His promise, you're absolutely correct, he did say that. But in fact, there are lawyer friends of mine that say that's really going to hurt him in the Supreme Court, because his argument is for federal powers, and now he has made a decision that returns the power to the state. Not going to play real well when the arguments on the constitutionality are argued. I'm not a lawyer. I can't go any further than that. But lawyers that I occasionally have a cup of coffee with tell me he may have really made a tactical error in terms of the judicial system with that one. Please. Oh, did I answer your question? Or did you have more to say? You may know more about it than I do. That's true. I'm not the font of all wisdom. These should be your comments. Teach me something as much as me asking you. Because this is just, I couldn't figure out how to use the mic today. So.
Regarding the electronic patient records that all of your doctors would be able to see, while I do think that is a fantastic idea and definitely something that needs to go into practice, how would you respond to privacy concerns over who could see that?
Okay, excellent question, and I'm probably going to stun you with my answer, and you're going to think I'm crazy, but I discover that a lot of people actually feel this way. Because I'm independent, I can actually get away with saying it. But I'm going to quote the guy that founded Yahoo. Privacy's over. Get it? Privacy's dead. Get over it. Okay, privacy is dead. And I've actually done some writing that. And you know that. Look at your Twitter accounts and your Facebook and the records. I mean, did you read the article in the New York Times Sunday a week ago about how much the phone companies know? Try to go out and do something you don't want somebody else to know about. Man, I guarantee you, AT&T and T-Mobile, they all know where you've been. They know where you spent your money. They know who you met in the bar. Privacy is over. I'm not joking. I'm not making this up. Okay, and so. Forget it. What we need to do, and I think the Genetic Information Non-Discrimination Act, which was passed a little over a year and a half ago, it makes this point, is we need to make it illegal to do anything to you based on what we may have learned about your health. And I go a step further. I think, as much as I obviously not very favorable towards the Affordable Care Act and the House version thereof, I think one of the worst acts we've got is HIPAA. And HIPAA really complicates. I mean, HIPAA is accountable for several cents on the dollar of the waste, the money that we have to spend to keep things. And then also, because of HIPAA, we're stopping people from being included in the real-time research studies that we could do, the comparative effectiveness, because they have to opt in, they have to agree to have their data studied. And a good healthcare system is going to be looking at that all the time. I want that. So I want my healthcare information out there in the database. And it's interesting, I'm not alone. This is actually a fairly widely held view. There are over 1,000 U.S. scientists that have now signed up to get their human genome, their entire genome sequenced, and to have it publicly available. Craig Venter did that. The very first genome that was sequenced was a scientist, Dr. Craig Venter. And now there are over 1,000 other professors at major universities, I'm sure a couple of them from universities here in Wisconsin, that have said, to make my point, I want my entire genetic sequence out in a public database. And I forget the name of the database, but it's got about 1,000 now. And someday when I got nothing else to do, I'm going to put my genes out there too. Because I want my health information searchable. I want my doctor and my pharmacist to be able to mine my database and find the associations, the things that maybe I forgot to tell them, you know, because we were rushed in that visit. So in my opinion, privacy's dead. Get over it. And now, is there a privacy advocate here? I've admitted right up front, I have a rather stunning answer. I can find thousands and thousands of people agree with me, but the majority position is probably still that we should protect the information. Please.
I'm not raising my hand because I'm a privacy freak. I'm raising my hand because we have all these competing interests that seem to be destroying us. We have things like HIPAA in the academic environment. We have FERPA.
Sure. Wait. Some of the people in the back are not hearing you.
You're going to get the mic.
That's okay.
Oh, I'm FERPA. Oh, I love it. FERPA.
My concern is that, my observation, I guess, and this question may be entirely rhetorical, but we have all these competing phenomena happening, and they're on collision courses with each other. We have privacy issues that are raised by HIPAA and FERPA, which is the academic version of HIPAA, and then we have institutional review boards that have to monitor and approve every experimental procedure and privacy rights and informed consent. And then we have statements like privacy is dead. Are there things that are okay to have privacy dead and other things that aren't? I mean, I guess the question that came up when we were having a conversation the other night, you know, as a preface to this event, if we're going to be putting all this data out there for everybody to mine to be able to make informed decisions, how do institutional review boards fit in? Does all this data and do the experimental designs have to be approved by them, or is there some mass, what's the word I'm looking for? Do they not have to do it?
Excellent question, because the research community is really vexed by a lot of these requirements and has become so bureaucratized that it's probably the consensus position, for example, that the FDA is now dysfunctional, you know, in terms of drug approval. And where it's even more dysfunctional than in drug approval is withdrawing drugs once the third and fourth stage trials show that the fast track stuff shouldn't have been approved. So, I mean, yeah, all of these mechanisms, it's hard, not just for me, but for most scientists to be very supportive of these things, but they are the law. I want to say hats off to the American Association for the Advancement of Science, AAAS, which has done a wonderful job of beginning to go back and ask these things. I'm no expert. I've never served on, well, I have served on institutional review boards, but I'm no expert in the policy issues. But like you, I think there are policy issues that need to be asked. And the AAAS, if you can go to AAAS.org, better yet, join Get Science, which is a wonderful journal, especially for you students that are in the health sciences. It's money very, very well spent. And AAAS is really asking those questions to the point that every given issue now has one or two articles or editorials raising these questions about how do we fix the broken research mechanisms, the broken data collection mechanisms. And quite frankly, in spite of all these oversights, why do we have so much research fraud? We have an incredible amount of research fraud. So we have these committees that are presumably making sure that everything gets done according to the best possible standards, and fraud is rampant. So I will back off and say I'm not an expert, but I will endorse what seems to me to be very reasonable efforts being pursued by AAAS and you students that are really interested in the health sciences, especially on the scientific, which would mean your biology students. I'd give the strongest possible endorsement. I think the student membership is still only $55. Is that correct? Yeah, it's the best buy you could get, in my opinion. Now, do you want to disagree with me on that? Yeah. So you want to get involved in that one, join AAAS. I'm a member, and I support them. And I don't know much about this, but I'm confident it's in good hands and being dealt with. Questions, comments, alternative points of view, please. I hate to posit this as just pure question and answer. It can be neat dialogue. Have at me. And by the way, those of you that saw me and Kevin together, you saw we disagreed a lot. Kevin and I have been best of friends for over 30 years. So yeah, we have. So it's fine to disagree and go home and have a beer afterwards. I'm in Wisconsin. I can say go home and have a beer and a brat. Excuse me.
You mentioned high tech at the beginning of your presentation. I wonder if you could talk about what you feel are its shortcomings and what you might put on your wish list for changes to it.
Okay, shortcomings and changes. Well, it's, as I said a moment ago, something I really have nothing good to say about. As the health reform law was put together, the high tech law was put together very, very quickly. In fact, the final versions, the language literally for this meaningful use stuff and the amount budgeted for it was put together in the final 48 hours before the bill was cast, purely to please the senator from Pennsylvania, having my senior moment here, Senator Specter, who was a Republican, who voted for it. You might remember that. And Specter voted for it, and then the following week became a Democrat. A little deal there, folks, and it had a lot to do with what went into high tech and kind of support for. I don't want to embarrass anybody here, but several of the largest IT companies happen to have their headquarters in Pennsylvania, and so there was a lot of special interests reflected in the law. And what it does is enshrines government authority to define the concepts of meaningful use. And the law says that it will be based on these quality indicators, the 80% measures that I already lambasted, and then allows the government to say that if you do those things and report on them, and in other words, if you go ahead and apply for your $46,000 to $64,000 if you're a physician, or for your $11 million maximum if you're a hospital, and if the regs don't change, and they already have, by the way, David Blumenthal changed the regs. The law is very clear that it had to be a set of phase 1, phase 2, phase 3 requirements. And Blumenthal said nobody's going to make phase 1 as it is, so they'll have a core of 10, and then you can choose 5 of the other 15. And nobody envisioned that coming because the vendors, that just threw them for a loop, because suddenly the vendors now that were going to be able to pick the magic 15 suddenly now have a possibility of every one of their clients having the same core 10, and then everybody could have 2 or 3 different 5. It's going to absolutely kill the vendor community to try to support that much. So it's not being implemented very much, as the good question before you mentioned, all the changes. Step back from that. And the point, healthcare IT is no longer rocket science. We know what works. We can look at good systems. We can look at Europe. Your student back here that asked the question about what can we learn from Europe. Most of the European countries, Denmark's paperless. Sweden's close. France has regions that are totally paperless. This is not right. We didn't need to go through all this, and then to create the extension services. I come from, I used to be UWM, the extension school. Okay, this idea of taking people and helping them go into the doctor's offices and recruiting people that have no experience with medicine, and giving that lots and lots of money. So it's not being properly implemented. It's over a 4-year period, 2011 through 2015, and we don't have that luxury. I didn't suggest anybody could sit and wait to find out for government regulations. We need the electronic records now, and there are some very good healthcare systems right here in Wisconsin that have already solved that problem and have excellent. You have 3 or 4 health systems in this state that have won national awards, for being amongst the stage 7 HIMSS users. We don't need a federal law. We all need to look at the people that have done it right, rather than hold off and do nothing for 2 years while we wait to see how the federal bureaucracy does it. And then Blumenthal, who I happen to think he's a really decent guy, but I think he was up against impossible. I mean, he's one of those people that's built a really good system. But now he's announced his resignation, and to be perfectly honest, I will be stunned if anybody other than a current government employee will take that position. So, leadership is not going to find it attractive. Sorry. You got anything good to say about high tech? Anybody here? In other words, you can't find a stronger supporter of information technology than me. But the government program that's trying to reinforce that, I think, is setting us back. The Health Maintenance Organization Act of 1973 did the same thing. It was based on what Kaiser Permanente did. In 73, Richard Nixon was still president, and he really saw the value of the Kaiser Permanente model. So he ramrodded through Congress the Health Maintenance Organization Act to set up HMOs, and they were all based on Kaiser's model. As soon as Kaiser read the federal regs, said, we're not having anything to do with this. And Kaiser did not seek certification as a federally qualified, because the federal regs were so ridiculous. If they had tried to comply, they would have had to go back years in what they were doing. And the same thing with high tech. The really good health systems aren't even thinking about trying to qualify because they're way beyond that. And that's, wouldn't you like to be like one of them rather than somebody standing in line for federal money? And then, interestingly enough, money that may never be appropriated, because remember who now controls the House Ways and Means Committee, and that's the Republicans, and they don't want to fund it. And so we're just waiting to see how the courts and the political system does it. So I just think that an awful lot of hospitals are going to discover they spent millions trying to get ready, and then the law will disappear. Or if the law stays, they'll discover they spent $15 million to get an $11 million federal benefit, and they're 3 years behind. I realize I'm being really antagonistic here. Anybody, please, somebody speak up and say something good about all this stuff. It's not my nature. I'm really an upbeat kind of guy. And you saw that, you know. I mean, that's it. It's imagining what you can do right here in Fond du Lac and not waiting for some bureaucrats to put in regs. And there's nothing, absolutely nothing I've talked about tonight that's rocket science for the future. Every single concept that I've mentioned, and that has been mentioned by, 15 people who have preceded me standing up here, maybe 20, these things all exist. It's just the will to put them together and remember the first law of parasitism.
If the healthcare law is struck down, what do we want to be looking out for in terms of negative proposals that might be coming out from other camps?
Yeah, if the healthcare law is struck down, what should we be looking for? The Republicans about 6 months ago came out with their plan. It includes things like tort reform, as if putting more cap limits. I mean, the Wisconsin law got mentioned in one of the panels with a $750,000 limit on non-economic damages. That's actually one of the Republican proposals for reasons that I can't even begin to understand. Part of the Republican alternative, the repeal and replace, would assume that tort reform would solve this problem. I can't draw a link between tort reform and any of the exciting things that I talked about. It doesn't bring us good genetic information. It doesn't tie us together. Our systems doesn't align. So tort reform isn't one. Selling insurance plans across state lines is another one. And that was mentioned by at least one of the people on the panel that was held here this afternoon. Given the regional differences in care and all of the very complicated actuarial things, it's hard for an insurance company to price a product in a market it controls under the state insurance commissioner. And I don't know really any insurance companies. I don't know any good health insurance companies, and there are plenty of them. I'm actually fairly defensive of the health insurance industry, and they're not my clients. I don't work for them. I think they've done some pretty good demonstrations. But I know enough about their business model to know that they struggle, the plans that are licensed in Wisconsin struggle to price plans based on costs of care in Wisconsin, the diseases that you have in Wisconsin, all of those things that actuaries look like. Suddenly to say they're going to go into an open market and sell a plan in Wyoming, give me a break. So what I think that unfortunately it would do, if we have that, is it'll draw very poor plans into the national marketplace. And actually the Republican plan also includes pushing the IT. High tech, interestingly enough, got a lot of Republican votes. So not a lot, but enough to say that it wasn't the bitter thing that most of the other legislation has been. So malpractice, and increasing the number of doctors. There's a big plan to push that. But if somebody just dumped enough money onto the medical education establishment right now in the United States to immediately start training more doctors, it would be 9 years before they'd come out. You need a year to get a faculty together, right? You just cannot organize a medical school faculty in less than a year. You need 4 years of undergraduate medical education, internship, 3 to 4 year residency. So even if the money were available to try and solve this by increasing medical education, our problems are today. And we just can't wait, so we need to use the technologies, the qualified non-physician practitioners, and those things aren't in the Republican plan. Anyone want to say anything in favor of the Republican? You know, I know there are a few Republicans in this. I've been watching the news. Pardon? Okay. Please. Yes,
I won't talk about politics because that's a bad topic.
Okay, that's fair.
I have a question that, you know, why is it that when I go to Fond du Lac Regional Clinic and give them all this information, and then I go to, which is an Agnesian, quote, company, and I go to St. Agnes, which is an Agnesian company, and they have different computers and I have to fill out the same damn piece of paper, and what is, if this is gone with this technology or paperless thing that you're talking about, what is that going to do to the profitability of different companies going into and selling it to different, like the Agnesian, to the hospital and that? What is that going to do to, I don't know even what the question is, but somewhere along the way, everybody's trying to make a buck by keeping their little pocket, you know, their little corner. And in the meantime, being a retired individual, I look at my Medicare EOB, and, you know, I go to a clinic, and it says that the doctor's charging me $300 for an office call, but because of his deal that he made with Medicare, he's only gonna get $80. So some poor son of a bitch that's working in a factory is gonna have to pay the balance of this because the hospital still has to make money. And I guess
you're eloquent, man.
I don't know.
I'm going to sign you up.
I don't know where I can be a. You know, Dr. Yal is a good friend of mine. He was my doctor when he first came to Fond du Lac, and I'm glad he's teaching here because I think he's got some sense. On the other hand, you know, he's got to make a buck too, okay?
Yeah.
And why is it that when I went to Sharp Clinic, if that was still in existence today, their computer couldn't talk to the hospital here? So I go to a lawyer because that's where my primary physician is, and I got to fill out the same damn piece of paper because St. Agnes can't talk to a lawyer because they hate each other. But competition is good, they say. So I'd like you to just comment on this whole mess.
What we need, I can't, you're eloquent. I love you. I'd love to, will you join the road show with me here? I need you as part of my act, if you will. Remember with Scottie Pippen, Dennis Rodman, Michael Jordan, the thing that showed up at first? That's what we're doing. They hate each other, by the way. It took a lot for Pippen and Jordan to get together when Pippen was brought into the Hall of Fame not too long ago. You probably read those stories. They really hated each other. And yes, they do, but somebody said our goal here is to win basketball games, right? And so it took Phil Jackson saying, Michael, you're not going to shoot quite as much. Rodman, you're going to rebound a little more. You know, somebody decided what the right division of labor is. And we need that leadership. So I agree totally. I'm sorry, that's a terrible Freudian slip. I agree with the idiocy of the system you just described. So we need people like you pushing for leaders that are going to get out there and make it happen. Because it is inexcusable. It is extraordinarily wasteful, and it doesn't have to happen. Okay? Anybody here with military health records? Yeah, I remember we talked about that. Do you have to keep filling out the same form in the military? No. They got one database. Transfers over to VA. It's fabulous. We could learn from the military. The military's got some great technology applications that we could learn from. But we need more people like you. See, and I've had it. You know, and I'm waiting for one of the health insurance technology companies to come out with an ad that says, you know, ask your doctor if they'll prescribe, you know, some colored pill for you. I want an onslaught of patients going through and start going to, and I'll say it, Agnesian and everybody else that's part of that three people that's at the top there that hate each other, and say, let's get our act together because it's important to us to save money and we realize how much you're wasting there. And so I want one of the health information companies to put out an ad saying, go to your doctor and say, why don't you have the Bauer system? I'll make that up. I don't have one. But, you know, why don't you have Bauer information technology? And, hey, that sort of fits. No, we need, hey, hats off to Marian for bringing you all together and having 2 days of wonderful interaction here, getting people a little bit uppity about something you can do something about. Because I can't defend it for a minute. Did you hear anything in my presentation that sounded like I was a show for the way it is today? No. But if you agree with me, I'm going back to Chicago. you know, and I got gigs in Louisiana and somewhere else next week. I hope to be back to Fond du Lac again soon. I've been here fairly often over the years. It's a neat place I enjoy coming back to. But you've got to make it happen. You can't have Jeff Bauer, Kevin Fickenshire coming in, your local experts making neat statements, until you, the people, get out there and say, I want an electronic record. Okay? I want the systems to talk to each other. And start getting the leadership at the community level to say, okay, people have spoken, it's going to happen. Does that make any sense? It's got to come from you. Now, remember, I'm a 60s, I didn't tell you a whole bunch about my background, but I was a real 60s college radical, okay? Shouldn't surprise anybody. Pardon? No surprise at all. And one of the things that I remember most fondly about the 60s, although as they say, if you can remember the 60s, you weren't there, think about it. But one of the things I remember most fondly about being a radical in the 60s, and I mean, I organized the first Earth Day in El Paso County, Colorado. I was part of the anti-war movement. I did all the radical things. I marched with Martin Luther King. Yeah, I mean, those were my movements, okay? And I believed in all those things. But what I really remember was Alice's Restaurant. In spite of how many of you remember Arlo Guthrie's song about Alice's Restaurant? Is that cool? You know, Guthrie gets thrown in jail in Massachusetts, strangely enough, for throwing trash into the wrong part of the dump. And so he comes up with this song, You Can Get Anything You Want at Alice's Restaurant, excepting Alice. And first he just sings it when he's being tested for the draft, and he's in there with, you know, I won't even go into the lyrics, it might offend a few people, but I do remember them well. And first thing you know, then more and more people sing it, and then all of a sudden there's enough people singing it that we change the national policy on Vietnam. And that's what it starts right here with a few people taking aside their friend that's on the board at Agnesian, taking aside their friend that works for Aurora. So let's get together. And it's interesting, I have a soft spot in my heart for Catholic healthcare. I started with Catholic healthcare. Most of my consulting clients over the years have been Catholic organizations. I really like Catholic healthcare. And I have, for the last 3 years, with great gratitude that they're even willing to do it, printed articles on exactly this point for the Catholic Healthcare Organization's magazine, Health Progress. And all 3 of my latest articles are available for free, and Catholic Healthcare has decided that they are worthy of a position in their journal. And they're all talking about how it takes people like you to get out there and say, we know you can do better. We demand it, especially because now we're being expected to pay for it. So we need the partnerships. Now, you can't go out and get a hospital to install an electronic record system, but you could start putting the pressure that gets up to Bob Foley and the people that run Agnesian, and gets up to the people that run the Milwaukee systems and the clinics. Say, get together, people, for crying out loud. You can have some influence on the state insurance commissioners. You know, you're not going to make the changes, but you can become that politically powerful group. So remember Alice's Restaurant. We need more people singing your tune. And I just came today to give you a few verses, but you're great. Yes, please, Dr. Ayala.
I know that you're considered a futurist, and I'd like to make a prediction. In the same manner that you said that the days of privacy are over, I'm going to tell the audience here that the days are coming that you will probably not see a physician when you get sick in the future. You're not going to see an internist, and you're not going to see a family practitioner. I'm sorry to say that. Even if we double the size of our medical schools, those young men and women are not going to go into private practice. And you better get used to it, that you will not be seeing a physician. And having said that, I want to have, I know that several times the comment has been made to increase the number of physicians or medical students, or increase the class of the medical schools. With all due respect, I don't think it's going to do any good, because we'll just have more physicians or medical students going into the specialties and not go into primary care. And frankly, unless you pay primary care physician a lot of money, I mean a lot of money, you're not going to change it. Now, also, I'm going to speak very frankly. In the medical school, there is a pecking order, a prestige order. In internal medicine, with all due respect to your son, internal medicine and family practice are not at the top of the pecking order. All right? when I went into internal medicine was considered the elite, the erudite, the eggheads went into internal medicine. Well, in the 30 some odd years that I've been out of medical school, that has changed. And the question that they ask medical students, what, you weren't smart enough to get into dermatology or radiology? Okay. So, having said that, I'm repeating what I said a while ago. My prediction is that the students here are going to be hard-pressed to see a physician in the future. You will see a nurse practitioner, and I'm hoping that the training that we give our nurse practitioners is going to be top-notch. So you will get the care that you need and require, but it's going to be a different kind of care. But very importantly, and I think it's been stated here this evening, it's going to have to depend on the care that we take care of ourselves. We have to take it upon ourselves to take preventive care. We don't do it.
Thank you. I really appreciate the comment.
Just to follow up on that.
Dr. Merrick.
When we talk about nurse practitioners, I don't know if there's any in the education and nursing education present here. It'd be interesting to see in the last couple classes of Marian, the nurse practitioners, how many actually went into primary care versus how many went into subspecialties. I believe, as I know, a high percentage did go to subspecialty practices. The same challenges that primary care physicians have, nurse practitioners are going to have the same challenges. That's not going to change.
Sad but true. But you, the people who demand the services, have got to get out there and ask for better from your healthcare systems. And I can say, as a person who works with them quite a bit, and encourage others in the audience, if in any way they disagree with me, we know how to do it. It's just overcoming this inertia and getting the different medical pecking orders to agree, all right, put this aside and let's build a good healthcare system. Within the health systems, between the health systems, across the professions, exactly what he just said is correct. Dr. Merrick's comment on the dilemmas facing the advanced practice nurses, absolutely correct. But it's got to come from some people demanding better of the system, and the reason I feel so comfortable getting excited about this is we know we can do it. But we have to reallocate our money. Another very clear conclusion from all of the discussion that's taken place in this very room in the last 48 hours is we've got to realign the payment system too. And that's going to take a Phil Jackson. I guarantee you, left to their own devices, Jordan, Pippen, and Rodman would have killed each other. And Chicago would not have teams to be proud of from 20 years ago. And this year too, by the way. I mean, I don't leave that unsaid. Sorry. But hey, remember, I'm a Green Bay fan, and go Badgers. I'm not all bad. And I do have a cheesehead. And I wore it. I even wore it the day the Packers played the Bears. I did. And discovered that our two neighbors who live across, kids, we were afraid, and one of them pulled out his. Cool. Now, I have been a Packers fan since the early 60s. I'm not a Johnny-come-lately on that one.
I think our time has come to an end.
Ooh, thank you.
This brings our symposium to a close. And I'd like to thank Jeff Bauer for his wonderful, wonderful talk tonight. Thank you.
Thank you very much. I'm counting on you to go do things.
I'd also like to remind you that Dr. Bauer has posted a number of his references, and there are a couple handouts, I believe, that are actually posted on the Marian website at the Academic Symposium site. For those who do not have access to a computer, there are approximately 50 copies of it on the tables outside. But if you do have access to a computer and you can access the Marian website, you just click on News and Events, Academic Symposium, and then
PDF files of all the articles.
PDF files of the presenters, and those items will be there. If you don't have access, you're more than welcome to take a copy from outside. And again, I thank all of you for participating. I thank all of our speakers. I thank thank our committee tremendously, and again, Agnesian, for helping us bring this about.
Thank you, Marian University, too. You deserve enormous credit. So.